You know, if you scroll through the comments section on pretty much any article about weight loss surgery, you are almost guaranteed to find this one specific sentiment repeated over and over again. It's this whisper or sometimes a shout that getting bariatric surgery is just taking the easy way out.
Oh, absolutely. It's the whole, cheat code narrative.
Right.
The idea is that while everyone else is out there grinding at the gym and counting macros, the surgical patient they just hit a button, fix the problem, and moved on.
Exactly.
Yeah.
And honestly, before we dug into the research for this, I think a part of me wondered if there was maybe some truth to that. But after looking at the data we pulled for you today, we've got reports from the Cleveland Clinic, the Mayo Clinic, and these massive long-term studies from the American Society for Metabolic and Bariatric Surgery. Well, that myth essentially just disintegrates.
It really does. Because what the data actually shows is that the quote-unquote easy way out is actually a rigorous, lifelong medical tightrope walk. It's not a magic wand. It's a major physiological intervention.
So that is our mission for this deep dive today. We're going to unpack the Roux-en-Y gastric bypass. We want to go way beyond the basic stomach stapling concept to help you understand the complex metabolic reset it actually triggers. We're going to look at the plumbing, the brain chemistry, the staggering remission rates for diabetes, and then
the part that usually gets glossed over in the glossy brochures.
Right.
The price of admission.
Right, the fine print. Because the price is high. We aren't just talking about a scar on your abdomen. We are talking about a fundamental alteration of how you eat, how you absorb nutrients, how you handle alcohol, and even how you reproduce.
Yeah, it rewires basically everything.
Let's start with the basics, though. The name itself is a bit of a mouthful. Roux-en-Y. I always thought it sounded like a street in New Orleans.
It does have that ring to it. It's actually a French term, meaning in the shape of a Y. And that shape is the key to the whole operation. To understand why, you kind of have to visualize the normal anatomy first. Your stomach isn't just this amorphous blob. It's a muscular bag, roughly the size of a football, that holds about 32 ounces of food.
Okay, so picture a football inside your torso. That's our starting point.
Right. And at the bottom of that football, you have the pyloric valve, which acts like a gatekeeper. It lets food out slowly into the intestines so your body can actually handle digesting it. Now, in a Roux-en-Y procedure, the surgeon basically ignores 95% of that football. They use a surgical stapler to partition off a tiny, tiny section at the very top of the stomach. We're talking about creating a pouch the size of a walnut.
Wait, hold on. We go from a football to a walnut.
A walnut, maybe a large egg if you're being generous. It holds roughly 1 single ounce of food.
Wow. So that's the restrictive part of the surgery people always talk about.
Yeah.
You physically cannot put a double cheeseburger into a walnut.
Exactly. You physically can't. But if that's all they did, it would just be a small stomach. The bypass part is where that Y shape comes in. The surgeon actually cuts the small intestine. They bring a section of it, it's called the roux limb, up and connect it directly to that new tiny walnut pouch.
So the food comes down the esophagus, hits the walnut pouch, and then immediately drops into this newly constructed highway.
Correct. It completely skips the rest of the stomach, and crucially, it skips the first part of the small intestine, which is called the duodenum.
And why is skipping the duodenum such a big deal?
Because the duodenum is the workhorse of your digestion. That is where a massive amount of chemical breakdown happens and where the body grabs the most calories and nutrients. By bypassing it, you create malabsorption. The body literally has less surface area and less time to grab calories from your food.
So you have a walnut-sized tank, and the fuel line is effectively cut in half.
That's a great analogy. But here is where it gets really interesting, especially in the recent literature from the ASMBS. For years, doctors thought this was just plumbing mechanics. Small tank plus short pipe equals weight loss. But the data shows it's actually a complete metabolic reset.
This is the part that completely blew my mind of the research. We aren't just changing the container, we're changing the chemical signals.
Precisely. You are rewiring the communication between the gut and the brain. When you bypass that upper intestine and dump undigested food into the lower intestine, it triggers a massive hormonal signal flare.
And this involves those acronyms we keep hearing about in the news lately, right? Like GLP-1.
Exactly. You've probably heard of Ozempic or Wegovy. Those drugs are designed to mimic a hormone called GLP-1. In a normal digestive tract, GLP-1 is released slowly when food hits the lower gut to basically say, hey, I'm full. But in a gastric bypass patient, food hits that area much faster and in a completely different chemical state.
Causing a flood of it.
Right, causing an absolute flood of GLP-1 and another hormone called PYY.
So the surgery is doing naturally well, surgically doing what those drugs are trying to do pharmaceutically.
Yes. These hormones just scream at the brain, satiety, stop eating. And simultaneously, the surgery lowers ghrelin. Ghrelin is often called the gremlin hormone because it's the one that makes your stomach growl and demands food.
So the gremlin gets quieter, and the I'm full signal gets turned way up. It's not just that you can't eat the burger. You chemically don't want the burger.
That is the metabolic shift. It effectively recalibrates the body's entire weight set point, and the results are undeniable.
Let's look at the scoreboard here for a second. The sources say patients typically lose 60 to 80% of their excess body weight.
Right. And notice the distinction there is excess weight. If you are 100 pounds overweight, you lose 60 to 80 pounds of that. And peak weight loss usually hits around the 18-month mark.
But for me, the real aha moment wasn't just the pounds lost, it was the diabetes data. We have this study from Geisinger Medical Center, and it's a massive data set. Over 2,000 patients followed for up to 20 years.
It's a landmark study in the field. What stood out to you the most?
The remission rates. They found that 54% of patients with type 2 diabetes were in complete remission at 3 years. But even more wild, 15 years later, nearly 40% were still in remission.
Think about the context of that for a second. Type 2 diabetes is traditionally viewed as a chronic progressive disease. You manage it, you take pills, maybe eventually you go on insulin, and it usually just gets worse over time. Here we have a surgical intervention that effectively puts the disease to sleep for decades.
And when they compared the surgery group to people with similar obesity and diabetes profiles who didn't get surgery,
The difference was a chasm. The mortality difference is just hard to ignore. In that same Geisinger study, the 5-year death rate for the surgery group was 0.68%. For the medically managed group, people trying to diet, exercise, or use medication, the death rate was 16.2%.
0.68% versus 16.2%. That is an 89% relative risk reduction. That's not a statistical error. That's a completely different life expectancy.
It effectively argues that for a patient with a certain BMI and health profile, not operating is actually much more dangerous than operating. It shifts the risk calculus entirely.
Now, before we move on to the harder stuff, I want to briefly touch on the sleeve gastrectomy because I feel like that's the one people hear about most often these days. How is that different from the bypass?
The sleeve is technically a simpler surgery. The surgeon removes about 80% of the stomach, turning it into a banana-shaped tube. But, and this is key, they don't reroute the intestines at all.
So the plumbing stays connected the exact same way.
Correct. So you get the restriction, the smaller stomach, but you don't get the malabsorption. It's generally safer in terms of vitamin deficiencies. But there is a specific reason why a doctor might push for a bypass over a sleeve.
Acid reflux, right?
Exactly. The sleeve creates a high-pressure tube. If you already have heartburn, the sleeve can turn it into an absolute nightmare. The bypass, because it diverts acid away from the esophagus, is almost a cure for reflux. So if a patient has severe GERD, the bypass is the gold standard.
Okay, so we've established the benefits. Massive weight loss, diabetes remission, solving reflux. It sounds like a medical miracle. But now we need to look at the fine print. Because the sources make it very clear you don't just wake up thin and order a pizza.
Far from it. The recovery diet is basically a boot camp. You spend the first 2 weeks on clear liquids, broth, water, sugar-free Jell-O. Then you slowly graduate to purees for weeks 3 through 6.
And I read about this one rule that every patient has to live by. Sip, don't gulp.
It sounds trivial, doesn't it? But imagine that walnut-sized pouch as a tiny funnel. If you dump a full glass of water into a tiny funnel all at once, it overflows. In the patient, that overflow causes severe pain, vomiting, or this intense pressure in the chest.
So you can't just chug water after a hard workout.
Never again. And you generally can't drink anything while you are eating solid food. You have to wait 30 minutes after a meal to drink because the liquid will wash the food through the pouch way too fast, leaving you hungry again.
That sounds incredibly socially awkward. Sitting at a dinner party, not touching your wine or your water while everyone else is eating and drinking.
It creates a totally new social reality. And speaking of awkward, we really have to talk about dumping syndrome.
The name is definitely evocative.
It's descriptive. And it's a direct result of bypassing that pyloric valve, the gatekeeper we mentioned earlier. Without the gatekeeper, if you eat sugar or fat, let's say a donut, That high-sugar sludge dumps straight into the small intestine.
And physiologically, the body just panics.
It's an osmotic shock.
Yeah.
The sugar concentration is way too high, so the body violently pulls water from the bloodstream into the intestine to dilute it. Your blood volume drops, your heart races to compensate, you break out in a cold sweat, get dizzy, and often have immediate explosive diarrhea.
It sounds like a full-blown panic attack combined with the stomach flu.
That is a very accurate description. And for many patients, it acts as a form of intense behavioral conditioning. You eat the donut, you feel like you're dying for 45 minutes, you don't eat the donut again.
So the surgery effectively installs a biological electric fence against junk food.
Ideally, yes. But there's a quieter, much more insidious risk than dumping. And this is where we get into the micronutrient malnutrition. This is the stuff that keeps the long-term clinicians up at night.
Because we bypass the duodenum, we bypass the primary absorption site for things like iron, calcium, and B vitamin.
Correct. You can eat the healthiest, most organic diet in the world, and you still simply cannot absorb enough nutrients to survive long-term without pharmaceutical help.
There's a case study from UVA Health in the reading packet that really stopped me in my tracks. It was a cautionary tale about a 60-year-old man.
Yes, this case is a stark reminder of the stakes. This gentleman had gastric bypass, lost 200 pounds on paper, a massive success, but about 14 months post-surgery, he stopped taking his vitamins. Maybe he felt fine. Maybe he just forgot or got tired of swallowing pills.
And the result wasn't just that he felt a little tired or sluggish.
No. He ended up in a wheelchair. He developed profound weakness, ataxia, which is a severe loss of bodily coordination and intense neuropathy. When they finally ran the labs, his copper and B12 levels were essentially non-existent.
I didn't even know copper deficiency was a thing you had to worry about.
Most people don't. But copper is essential for the spinal cord. He had essentially developed a condition called Wernicke's encephalopathy, which mimics severe spinal injury. And the real tragedy is, even after they identified it and pumped him full of supplements, he didn't fully recover.
The damage was already done.
He went from a wheelchair to a walker, but the neurological damage was largely permanent.
That is terrifying. It turns the surgery from a fix-it moment into a chronic management situation.
That's the trade-off. You trade the chronic disease of obesity for the chronic management of nutrition. You have to take high-dose multivitamins, calcium citrate, specifically citrate, by the way, because carbonate requires stomach acid to break down, which you don't really have anymore, iron, and B12 every single day for the rest of your life.
And you have to look out for weird signs. The sources mentioned a beefy red tongue for B12 deficiency or corkscrew hairs for vitamin C deficiency.
Scurvy. We are talking about literal scurvy. It's rare, but it happens in bariatric patients who ignore their regimen. If you see corkscrew hairs or bleeding gums, you are seeing a disease that plagued sailors in the 1700s, right here in the 21st century.
So assuming you manage the vitamins and you prioritize protein, because if you don't get 60 to 100 grams a day, your body will literally eat your own muscles. There are still other hurdles. Let's talk about the social side, specifically alcohol.
This is a major topic. Post-bypass, you have a completely new metabolism for alcohol. Because the stomach isn't there to break down the ethanol with enzymes, and the food doesn't slow it down, alcohol hits the bloodstream like a freight train.
So one glass of wine hits you like 3 or 4.
Fast and hard. Your blood alcohol level spikes much higher and much faster than it ever did pre-surgery. But the Mayo Clinic source raises a darker issue here. Addiction transfer.
This is the psychological component.
Right. For many patients, food was a coping mechanism. It provided a reliable dopamine hit. When you surgically remove the ability to binge eat, that need for a coping mechanism doesn't just vanish. If the patient doesn't do the psychological work, they might swap the food for alcohol.
And considering the physiological sensitivity we just talked about, that is a recipe for rapid onset alcoholism.
It is. We see higher rates of alcohol use disorder in post-bypass patients starting around year 2. That's why many programs require total abstinence from alcohol for at least the first year.
Let's pivot to something that affects a different demographic, but is equally complex. Pregnancy. We know obesity is a major driver of infertility, specifically with conditions like PCOS.
Yes. Adipose tissue, or fat, is hormonally active. It messes with estrogen and testosterone balances. As the weight drops post-surgery, that balance often corrects itself.
So fertility spikes.
Sometimes dramatically. We have patients who were told for years they could never conceive. who suddenly find themselves pregnant 4 months after surgery.
Which sounds like a dream come true, but I'm guessing there's a but.
There is a massive but. Getting pregnant during the rapid weight loss phase is dangerous. The mother is in a catabolic state, meaning her body is breaking down tissue for energy. But a developing fetus needs an anabolic state, building tissue.
So the fetus is competing for nutrients in a body that is effectively starving itself.
Exactly. It increases the risk of small for gestational age babies. Plus, there is another wrinkle. Oral contraceptives might not work.
Because of the malabsorption we talked about earlier.
Right. The pill needs to be absorbed in the digestive tract. With a bypass, that reliability drops. So you have super fertile women taking potentially ineffective birth control while their bodies are physically not ready to support a baby.
That is a very tricky needle to thread.
It requires careful planning. The clinical guideline is strict. Avoid pregnancy for 12 to 24 months. Use an IUD or a non-oral method. Once the weight stabilizes, pregnancy outcomes are actually much better than they would have been with obesity. You see lower preeclampsia risk, lower gestational diabetes. But timing is everything.
There is one last physical change we have to address for you to really grasp the full picture: the skin. You lose 150 pounds, that skin doesn't just snap back.
No, skin has elasticity limits. If you've been overweight for years, that skin has stretched permanently. When the fat is gone, the skin remains. Patients are often left with an apron of skin hanging from the abdomen and loose skin on the arms and thighs.
And the sources emphasize this isn't just vanity. This causes real medical issues.
Rashes, intertrigo, which is a nasty yeast infection in the skin folds, skin breakdown, ulcers. It can be physically painful just to exercise because of the heaviness of the excess skin. We're talking 40 to 60 pounds of skin in some cases.
The heartbreaking part for me was reading about the insurance battles. You do this massive thing for your health, you succeed, and then the insurance company says skin removal is purely cosmetic.
It is a constant fight. Unless you have documented chronic infections that don't respond to treatment, it is very hard to get coverage for removal. So patients often face a 5-figure bill to finish the journey they started. They've fixed the inside, but the outside doesn't match yet.
It seems like the recurring theme here is that the surgery solves one massive life-threatening problem, obesity, and its metabolic consequences, but it introduces a whole new set of challenges that have to be managed.
That is the perfect summary. Gastric bypass is not a cure. It is a tool. Think of it like giving a carpenter a power saw instead of a handsaw. It's incredibly powerful, it speeds up the work, but if you don't respect it and use it correctly, you can do serious damage.
And that user manual involved vitamins for life, protein prioritization, watching the booze, and navigating a totally new body.
It's a marriage between the surgeon's work and the patient's behavior. The surgeon fixes the plumbing, the patient has to fix the lifestyle. You cannot have one without the other and expect long-term success.
So, to go back to where we started today, is it the easy way out?
If easy means taking a handful of pills every morning, worrying about your copper levels, risking dumping syndrome every time you eat out, and completely overhauling your relationship with the world, then sure, but I think anyone can see it's actually just a different hard.
A different heart. I like that. You're trading the heart of diabetes and immobility for the heart of discipline and maintenance.
Exactly. And for the right patient, that trade is life-saving, but it is not free.
I want to leave you, the listener, with a final thought based on all this. It makes you wonder, if changing the plumbing of your gut completely rewires your desires, your cravings, and even your addictions, how much of what we call willpower is just biology? It really challenges the whole concept of free will when it comes to human appetite.
Couldn't have said it better. The surgery buys you time and opportunity, but it doesn't live your life for you. The new normal is something you have to build yourself.
That is a powerful place to leave it. Thank you for walking us through the plumbing, the chemistry, and the reality.
My pleasure.
And thank you for joining us for this deep dive. We'll see you on the next one.